This is Dr. Mimi Lamb from Metro Health Medical Center, and I would like to explain to you the concept of cardiorenal syndrome, what it is, and why it happens. There's no universally accepted definition of cardiorenal syndrome, but it is described as being a condition in which there is a dysfunctional interaction between the heart and the kidneys. This can occur in one or both directions, can be acute or chronic, reversible or irreversible. So what I'd like to go over for you in this video are these three things. How do the heart and kidneys work together normally? What happens if one fails? And what happens if both fail? First, how are things supposed to work? Normally, the heart and kidneys work together like this. The heart pumps out blood to perfuse organs, including the kidneys, and supplies them with oxygen and nutrients. The kidneys regulate extracellular volume, excrete metabolic waste products, and allow the heart to function at maximal efficiency. Each organ depends on the other for normal function. For the kidneys to function, they require adequate blood flow and delivery of oxygen and nutrients. If heart failure develops, cardiac output is decreased and renal blood flow is reduced, which can result in reversible and sometimes irreversible renal damage. For the heart to function, it requires regulation of extracellular volume. If ECF volume is too low, there is inadequate blood volume to support cardiac output. If ECF volume is too high, fluid leaks out of the capillaries, resulting in edema. So with that introduction, let's look at examples of the relationship between cardiac and renal function. We'll start by thinking about what happens when one organ system fails and how that affects the other. First, if the heart fails, how do the kidneys respond? If the heart fails, cardiac output drops and stroke volume falls, and the result is a drop in renal blood flow and GFR. With impairment of waste excretion, as well as activation of a neurohormonal response that results in increased sodium and water reabsorption by the kidneys. So let's take a minute to look at that response. With heart failure and the fall in cardiac output and stroke volume, the baroreceptors in the aortic arch and carotid arteries detect the smaller stroke volume because they're stretched less than they would be by a normal stroke volume. This is what we call a decreased effective circulating volume, because even though intravascular volume is normal, it is perceived by the baroreceptors as being abnormally low, and this sets in motion a neurohormonal response that is intended to correct a low intravascular volume. The renin-angiotensin-aldosterone system, sympathetic nervous system, and ADH secretion are all activated. Increased renal sodium and water reabsorption result, and intravascular volume increases, which is the appropriate response when a low stroke volume truly reflects a low intravascular volume. Even in heart failure, sodium and water retention can initially be a good thing because it results in increased preload for the failing ventricle. And why is that good? Because it tends to push cardiac output higher along the Frank-Starling curve, even though the slope of the curve is flatter in heart failure than in normals. Here's a normal left ventricular filling pressure with a normal cardiac output on a normal Starling curve. In heart failure, the same LV filling pressure gives you a lower cardiac output on the flatter curve. But if preload increases because of sodium and water retention by the kidney, filling pressure moves a little farther along on the failing Starling curve and gives you a little increase in cardiac output. Now, back to our flow diagram. Although the increased intravascular volume initially helps by increasing preload, it also increases capillary hydrostatic pressure and allows fluid to leak out into the interstitium, causing edema to form in the soft tissues and even in the alveoli. The failing heart also contributes to edema formation in another way, by causing pressure to back up on the venous side of the circulatory system, so that venous pressure is transmitted back to the capillaries. So you have both increased venous pressure behind the failing heart and increased sodium and water retention contributing to the imbalance of Starling forces that allows edema to form. So that's what happens when the heart fails and the kidneys try to respond. But before we talk about the badness that results from all of this, let's see what happens when the kidneys fail and the heart tries to respond. If the kidneys fail, renal blood flow and GFR decrease, and extracellular fluid volume increases. The heart attempts to deal with this extra volume by increasing its output. Sympathetic nervous activity increases, causing increases in heart rate and cardiac contractility, allowing the heart to handle the large ECF volume at least for a while. However, if the heart is also not working normally, we now encounter the combination of heart failure and kidney failure. There are several ways that this combination can develop, and for this reason, cardiorenal syndrome is officially classified into 5 types. While it's not important to be able to recite these, it is helpful to realize that there are several ways in which these two organ systems can make each other fail. Acute heart failure can cause acute kidney injury. Chronic heart failure can contribute to chronic kidney disease. An acute decrease in renal function can lead to acute cardiac dysfunction and heart failure. Primary chronic kidney disease can contribute to cardiac dysfunction, and an acute or chronic systemic disorder can result in both cardiac and renal dysfunction. So how does this happen? If both organ systems are abnormal to start with, how can dysfunction in one system actually worsen the other? This is how cardiorenal syndrome begins. So let's look at this dysfunctional relationship from both points of view. First, how can heart failure worsen kidney failure? There are several mechanisms by which this can happen. As heart failure worsens and stroke volume falls, the lower cardiac output leads to even lower renal blood flow and GFR. High right-sided or venous pressures in the vascular system also affect renal venous pressure, impairing renal blood flow and GFR even more. Decreased cardiac output also leads to decreased delivery of oxygen and nutrients to tissues, including renal tissue, resulting in further damage to susceptible kidney tissue and blood vessels that are already damaged by pre-existing diseases such as diabetes and hypertension. So when heart failure induces renal sodium and water retention via baroreceptors and renin angioactivation, this may now be combined with underlying renal disease wreaking havoc on waste excretion and volume regulation. Now let's look at the opposite view. How can kidney failure worsen heart failure? Increasing renal failure can make the heart's job more difficult and can damage cardiac tissue and function in several ways. As the kidneys fail and intravascular volume increases, cardiac muscle function is impaired because the muscle fibers are stretched beyond their optimal working length, reducing their efficiency. The high intravascular volume also results in alveolar edema, which leads to impaired gas exchange and decreased oxygenation of tissues, including the myocardium. Edema of the myocardial tissue can contribute to increased ventricular stiffness and impaired contractility. There is even an entity called uremic cardiomyopathy, characterized primarily by left ventricular hypertrophy and diastolic dysfunction, which is attributed to a variety of mechanical factors, uremic toxins, proteins, and cytokines that accumulate or are produced in renal failure. And kidney disease frequently includes increased vascular resistance mediated either by vasoconstriction, like increased renin angioactivity, or by hypertension with vascular damage and scarring. This increased vascular resistance translates to increased afterload, which can further impair the contractility of the failing myocardium. So now we can see the beginnings of a downward spiral, with decreased function in each organ system contributing to even worse function of the other. Decreased stroke volume and effective circulating volume caused decreased perfusion pressure and activate the renin angio and sympathetic nervous systems, resulting in vasoconstriction with increased cardiac afterload, as well as decreased renal blood flow, GFR, and increased renal sodium and water reabsorption. This leads to increased extracellular fluid volume, resulting in overstretching of cardiac muscle, reducing its efficiency, as well as increasing renal venous pressure with further impairment of renal forward blood flow. The increased ECF volume also results in edema in both the tissues and alveoli, impairing myocardial contractility and increasing its stiffness, and impairing alveolar gas exchange to cause decreased oxygen delivery to the tissues, resulting in sometimes irreversible cell damage. And vasoconstriction plus renal failure from the underlying renal disease results in accumulation of metabolic waste products, which contribute to the development of uremic cardiomyopathy. This decreased function of both organ systems has familiar clinical consequences. The patient now has symptomatic heart failure and renal failure and needs to be treated with supplemental oxygen, diuretics, afterload reducers, inotropic agents, etc. But with both organ systems functioning poorly, management and therapy become a delicate balancing act. Here are two examples of that balancing act, probably the most common presentations of cardiorenal syndrome. First, giving diuretics may seem like a good idea in order to reduce peripheral and pulmonary edema, but large intravascular losses may result in hypotension, decreased preload, even less renal perfusion, a lower GFR, and increasing levels of BUN and creatinine. Large doses of diuretics can also result in electrolyte imbalance, especially hypokalemia and contraction metabolic alkalosis. Another example of trying to balance benefit versus risk in managing cardiorenal syndrome is the use of ACE inhibitors, which reduce afterload and stress on the failing myocardium, but in the process of decreasing vasoconstriction in various vascular beds, an ACE inhibitor also preferentially dilates glomerular efferent arterioles, reducing hydrostatic pressure in the glomerular capillaries and resulting in a lower driving force for glomerular filtration, sometimes with disastrous consequences on metabolic waste excretion. So when both organ systems are failing badly, it is sometimes possible to achieve a balance using potent combinations of IV diuretics, afterload reducers, IV or oral inotropic agents, IV vasopressors, intensive oxygen supplementation, mechanical ventilation, dialysis or CVVH to reduce volume and to clear solutes, and even a left ventricular assist device, or LVAD, to bolster cardiac output. But there is then the risk of trapping the patient in a high-maintenance, technology-dependent existence that often is not sustainable in a long-term way. The outcome of cardiorenal syndrome depends on the degree of dysfunction in each organ system and the amount of reversible damage to each. Often the best that can be hoped for is to arrive at a therapeutic plan that includes diet, diuretics, antihypertensive meds or pressors, inotropes, dialysis, etc., to achieve an acceptable balance between low cardiac output, decreased renal function, and increased intravascular volume, a delicate balance that supports a life of limited activity but still allows for enjoyment of things that are important to the patient. So that's it. And please feel free to contact me if you have questions, comments, criticisms, or rebuttals on this complicated topic, which has been described from the viewpoint of a nephrologist.